Welcome everyone. I'm Ben Osevwe, DNP-PMHNP-BC, producer of this educational video, brought to you by Soli Foundation Psychiatry and Rotation Match Network. Today, we are talking about anxiety disorders. Anxiety is one of the most common concerns PMHNP students and psychiatric providers will encounter. But here is the clinical challenge. Anxiety is not always just anxiety. A patient may say, "I worry too much. I feel on edge. My heart races. I cannot sleep. I avoid people. I feel like something bad is going to happen." Or, "I feel like I'm dying during panic attacks." But as PMHNPs, we must ask, is this generalized anxiety disorder, panic disorder, social anxiety, PTSD, OCD, ADHD, bipolar disorder, substance-induced anxiety, a thyroid problem, cardiac symptoms, medication side effects? That is why careful assessment matters. In this video, we will cover what anxiety is, how to assess anxiety disorders, key diagnostic criteria, differential diagnosis, medication choices, symptom-based medication matching, psychotherapy options, and a short case study to bring everything together. This video is for educational purposes only. It is not medical advice and does not replace clinical judgment, supervision, emergency evaluation, or your organization's policies and state practice guidelines. For any patient with suicidal thoughts, homicidal thoughts, psychosis, severe functional decline, chest pain, severe shortness of breath, syncope, intoxication, withdrawal, or inability to maintain safety, follow emergency protocols and escalate care immediately. Anxiety is a normal human response to threat, uncertainty, pressure, or danger. In the right amount, anxiety can help us prepare, focus, and stay alert. But anxiety becomes a disorder when fear, worry, panic, avoidance, or physical symptoms become excessive, persistent, difficult to control, and impairing. Anxiety affects the mind and the body. Mentally, patients may experience worry, fear, racing thoughts, poor concentration, irritability, dread, or a sense that something bad will happen. Physically, they may experience palpitations, sweating, trembling, chest tightness, shortness of breath, nausea, dizziness, headaches, muscle tension, restlessness, fatigue, and insomnia. Behaviorally, anxiety often leads to avoidance. The patient may avoid school, work, driving, crowds, social events, presentations, stores, elevators, conflict, or medical appointments. The key clinical pearl is this: anxiety is not only a feeling, it is a pattern of thoughts, body symptoms, behaviors, avoidance, impairment, and safety concerns. Here is your first question. What is the behavior that often keeps anxiety alive? The answer is avoidance. Avoidance brings short-term relief, but it often reinforces long-term anxiety. There are several anxiety-related conditions PMHNP students and providers should understand. Generalized anxiety disorder, or GAD, involves excessive anxiety and worry about several areas of life, such as health, finances, school, work, family, or everyday responsibilities. Panic disorder involves recurrent, unexpected panic attacks and ongoing worry about having more attacks or changing behavior because of the attacks. Social anxiety disorder involves intense fear of social situations where the person may be judged, embarrassed, humiliated, or negatively evaluated. Specific phobia involves intense fear of a specific object or situation, such as flying, heights, animals, blood, injections, or enclosed spaces. Agoraphobia involves fear or avoidance of situations where escape may be difficult or help may not be available. It is also important to know what anxiety can overlap with: PTSD, OCD, depression, ADHD, bipolar disorder, and medical illness. Let's start with generalized anxiety disorder. GAD is characterized by excessive anxiety and worry occurring more days than not, for at least 6 months, about a number of events or activities. The person finds it difficult to control the worry. The anxiety and worry are associated with symptoms such as restlessness, being easily fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. The symptoms cause clinically significant distress or impairment in social, occupational, academic, family, or other important areas of functioning. The symptoms should not be better explained by substances, another medical condition, or another mental disorder. Here is your question. How long must excessive worry usually be present for GAD? The answer is at least 6 months. Now let's talk about panic disorder. A panic attack is a sudden surge of intense fear or discomfort that peaks within minutes. Symptoms may include palpitations, sweating, trembling, shortness of breath, choking sensation, chest pain, nausea, dizziness, chills or heat sensations, numbness or tingling, derealization, fear of losing control, or fear of dying. But having one panic attack does not automatically mean the patient has panic disorder. Panic disorder involves recurrent, unexpected panic attacks, followed by at least 1 month of persistent concern about additional panic attacks or their consequences, or a maladaptive change in behavior related to the attacks. Question: what makes panic disorder different from a single panic attack? The answer is recurrent unexpected panic attacks, plus ongoing worry or behavior change afterward. Social anxiety disorder is more than shyness. It involves marked fear or anxiety about social situations, where the person may be scrutinized by others. The patient may fear being judged, embarrassed, rejected, humiliated, or seen as anxious. Common triggers include public speaking, meeting new people, eating in public, dating, using public restrooms, or being observed. The social situations are avoided or endured with intense fear, and the fear is out of proportion to the actual threat. Symptoms are typically persistent and impairing. Here is a clinical pearl. Many patients with social anxiety do not say, "I have social anxiety." They may say, "I hate attention," "I don't like people looking at me," "I avoid presentations," or "I overthink everything I said." A strong PMHNP anxiety assessment should be systematic. First, identify the main concern. Ask, what does anxiety feel like for you? When did it start? What triggers it? What do you avoid because of it? Second, determine the type of anxiety. Third, assess duration, frequency, and impairment. How long has this been going on? What has the patient stopped doing because of anxiety? Fourth, assess physical symptoms. Fifth, assess safety. Anxiety can coexist with suicidal thoughts. Sixth, screen for bipolar disorder, especially before starting antidepressants. Seventh, assess substances and medications. Eighth, assess medical contributors. Ninth, use measurement tools when appropriate. The GAD-7 is commonly used to measure anxiety severity. A simple framework is symptoms, triggers, avoidance, impairment, safety, bipolar screen, substances, medical causes, and function. Not every anxious patient has an anxiety disorder. Differential diagnosis is essential. First, consider medical causes. Hyperthyroidism, cardiac arrhythmias, asthma, COPD, and anemia can mimic anxiety. Second, consider substance-induced anxiety. Caffeine, stimulants, cannabis, and alcohol withdrawal can worsen anxiety. Third, consider major depressive disorder. Fourth, consider bipolar disorder. Anxiety may occur during mixed states. Fifth, consider PTSD. Sixth, consider OCD. The anxiety is driven by ritual behaviors. Seventh, consider ADHD. ADHD can cause restlessness and performance anxiety. 8th, consider psychotic disorders. 9th, consider autism spectrum disorder. Differential diagnosis matters because the wrong diagnosis can lead to the wrong treatment. Now let's talk about medication choices. For GAD, panic disorder, and social anxiety disorder, common first-line medication options include SSRIs and SNRIs. Sertraline is often a strong choice when anxiety overlaps with depression or OCD. Escitalopram is chosen for tolerability and simplicity. Fluoxetine may be more activating. SNR is like venlafaxine, and duloxetine are also used, with duloxetine being helpful for comorbid pain. Buspirone is useful for GAD when the patient wants a non-controlled option. Hydroxyzine may be helpful as needed for acute anxiety. Propranolol may be helpful for performance anxiety, like public speaking. Benzodiazepines like lorazepam and clonazepam reduce anxiety quickly, but are not first line because of risks including dependence and withdrawal. If used, they should be short-term and carefully monitored. Treat bipolar first. Be careful with antidepressants alone. Medications can help, but psychotherapy is a major part of anxiety treatment. Cognitive behavioral therapy, or CBT, is one of the most important treatments. CBT helps patients challenge anxious thoughts and reduce avoidance. Exposure-based strategies are especially important for panic and phobias. Relaxation skills like diaphragmatic breathing and mindfulness also matter. Remember, reassurance alone does not cure anxiety. Skills and exposure are key. Let's apply this to a short case. A 24-year-old graduate student presents with constant worry for the past 8 months. She worries about school, finances, and disappointing people. She drinks 4 cups of coffee daily. Question: what are your first 3 priorities? A good PMHNP answer would be: first, clarify the anxiety pattern. Second, assess safety and impairment. Third, rule out bipolar disorder, medical contributors, and caffeine-related anxiety before selecting treatment. Her presentation is consistent with GAD. A reasonable management plan includes psychoeducation, reducing caffeine, CBT referral, and GAD-7 monitoring. If she prefers medication, an SSRI like sertraline may be considered. If she has chronic pain, duloxetine. If she wants a non-controlled option, buspirone. Follow-up should monitor severity, side effects, and functional goals. Here are your high-yield PMHNP pearls. Anxiety is not just worry. It includes body symptoms and avoidance. Avoidance keeps anxiety alive. Always assess suicide risk. Always screen for bipolar disorder before starting antidepressants. For GAD, remember the 6-month rule. For panic disorder, remember recurrent attacks and concern. Social anxiety is fear of scrutiny. Medical causes can mimic anxiety. Anxiety disorders are common and treatable. As PMHNPs, our job is to assess carefully, rule out other causes, and help patients reduce avoidance. Thank you for watching this educational video from Soli Foundation Psychiatry and Rotation Match Network. For mentorship and clinical growth, connect with Rotation Match Network. Continue learning and growing into a safe, confident PMHNP provider.